Thank you so very much, Dr. Sharma, and it's such a absolute privilege to be here with you all. You can always sense the passion of a place and its forward-looking direction just by the tone and the energy and the vibrancy in a room. And if there was anything that you take home from the last talk, it is passion and vibrancy, and I congratulate you for that. Legacy in a place is always determined by the resilience of their people and the forward-looking momentum. And we have such wonderful people here, masters of technique, masters of research, masters of policy, leaders that are second to none. I miss some of my friends who have uncharacteristically moved from Boston to New York a few years ago, like Deepak did. I know he is doing great, but I miss talking to him every day, Roxana, and it was one of the things that I missed the most. So it's such a privilege to be here. And I'll take you on a very quick odyssey of what I think are the top 10 or so advances in the field. But as I thought about it, my thinking was that I not only want to show you what is now practically clearly possible in terms of advances, but also advances in thinking and advances in science that will clearly shape our immediate future. So let's go on this journey, and first let's establish where we are today. Quite clearly, we now think of heart failure in a universal definition, and that universal definition really has just three domain characteristics to it: early left ventricular dysfunction, symptomatic persistent heart failure. We've gotten away from calling it chronic stable heart failure because we understood that by calling it stable, people developed a general inertia to therapy. So we changed the nomenclature to symptomatic persistent heart failure so that people would understand that it is a disease associated with residual risk and needs to continually be treated. And then there's this group of advanced heart failure patients. And the real distinction between these groups is that one is tackled through a neurohormonal and metabolic therapy pathway, while the other, at the extreme end, the 10 or 15% of patients who transition to advanced heart failure demonstrate exhaustion of the neurohormonal axis. So there are a number of foundational therapies. But what's the real challenge with all of this? The real challenge here is implementation. As much as the progress has been made in this field, we have a tremendous implementation gap, such that while most people would say that, about 70% of people are on foundational therapy in our place, when you actually look at the data very carefully and you ask how many of them are on target doses of those foundational therapies, turns out it's somewhere between 1 to 15%, depending on the institution. So clearly we have a lot of work to do, and these efforts need to be moved forward in a positive way. One of my former fellows and now a very prolific scientist, Madhu Vaduganathan, worked with Scott Solomon some years ago and actually created this idea of how much life prolongation can be had with ensuring this foundational therapy and implementing it. And it turns out that for a 55-year-old or a 65-year-old, the typical population of patients that we see, there is as much as 6 to 8 years of life prolongation that can be attained. Now, of course, the challenge with creating data like this is that the assumptions here are that there's perfection of 100% access to therapy and more than 90% adherence to therapy and very low adverse event rates. And in the real world, that's just not true. So we don't get to see that. And somewhere along the paradigm shift that we have with these therapies, we get perhaps only 1/5 of the life prolongation that we actually could get with these therapies. Now, I will start by pointing out that William Withering, who introduced digitalis to us and cardiac glycosides in a clinical manner, is still alive and well. And Withering's digitalis seems to not have completely withered, as we have seen recently. And I'll share with you where that data is at this time point. So we are moving from digoxin to digitoxin, and there's been a reemergence of cardiac glycosides, at least in terms of data, somewhat weak, but still of significance to discuss today. Back in 1997, Salim Yusuf and others really pushed the mantle forward by investigating digoxin in the DIG study in sinus rhythm patients with heart failure. And in the primary endpoint of this was all-cause mortality, and that was not affected by digitalis and digoxin at that time point. There was an increase in toxicity, so people just didn't pick it up, because in those days, most of the clinical trials, like with ACE inhibitors and beta blockers, were looking at mortality-related outcomes. And one would only advocate therapies in that realm at that time point, back in the late 90s. Turns out that if you look at the secondary endpoints, and if they were actually adjudicated in the light of today's data, you would actually consider it a potentially approvable drug from the data that was presented in 1997, because the combined endpoint of all-cause mortality or heart failure hospitalization appeared to be significant. Even hospitalizations for heart failure alone were clearly quite significantly decreased, and death from worsening heart failure itself almost reached significance around that time point. So this really resulted in not much use of digitalis and digoxin. And in fact, there were challenges in the sense that women who were exposed to digitalis in the trial were disadvantaged to some extent, with a signal of increased harm in later studies that came out, secondary post-hoc analyses, and they really created a dissonance in our thinking of not using digitalis, and we stopped using it generally. Until recently, the DIGIT-HF trial was published. This used digitoxin, not digoxin. So there are two glycoside plants, digitalis lanata, from which digitoxin is created, and digitalis purpura, from which digoxin is created. Digitoxin is a longer acting and hepatically cleared molecule. And in this study, which only included 1,200 patients randomized to a placebo-controlled arm, there was clearly a significant reduction in the primary endpoint of death from any cause or heart failure hospitalization. Very modest. You see the curves actually converging again, but it's also because they didn't have enough patients to follow in the long run. The bottom line with this trial is that it was underpowered. They really wanted to enroll 2,400 patients. And if you think about it, the entire number of patients enrolled in the DIGIT-HF trial was half the number of deaths in the DIG heart failure trial in 1997. So clearly the fidelity and precision of this data is questionable, but yet it did raise the issue from one standpoint, and that is, if you look at the combined all-cause mortality or heart failure hospitalization endpoint from the DIG-HF trial, and you look at the same endpoint in this trial, they look eerily similar, suggesting that if instead of digitoxin or digoxin, you call this an SGLT2 inhibitor, for instance, in HFpEF, you might actually have considered it as reasonable therapy in patients with heart failure. Now, a few things about foundational pillars of therapy in HFpEF. In the old days, whenever we would present a data on heart failure, and the first slide on heart failure with preserved ejection fraction used to be a blank slide. We used to say, here's the evidence for HFpEF. And now I'm pleased to tell you that that's no longer the case, and there are at least 3 reasonably foundational therapies that I would argue have withstood some of the scrutiny and clinical trials in HFpEF. Those include mineralocorticoid receptor antagonists, SGLT2 inhibitors, and GLP-1 agonists. And I'll just very quickly run through where the advances in this are and where the current understanding is in the field. So the first trial in this was the TopCat trial, which was conducted from the Brigham by Mark Pfeffer and colleagues. And this trial actually was a neutral primary endpoint trial until it became obvious that there was some significant geographic heterogeneity, which is shown over here. That if you look at the Americas, which basically includes Canada and the United States, compared to Russia and Georgia, that not only was there a discriminatory component to the frequency of events across across these two regions, but that if you only isolate the data to the Americas in this post-hoc analysis, that there was a clear reduction in the primary endpoint of CV death, aborted cardiac arrest, or heart failure hospitalization with a hazard ratio of about 0.82. It's important to keep that in mind because we now have another trial with finerenone, which is a non-steroidal MRA, that actually suggested the exact same thing. And if you look at the rate ratio in this case, not the hazard ratio, but the rate ratio, it's about 0.84 for the same endpoint, suggesting, again, very much like the digitoxin and the digoxin trials, similarity in these endpoint outcomes, suggesting that this is a very reasonable therapeutic stance in HFpEF patients or those with an EF above 50%. Now, whether a steroidal MRA is better than a non-steroidal MRA remains an open question at this time point. And while we think that there might be a lower rate of adverse events with non-steroidal MRAs, what is more important is access to this therapy and making sure that people get one of these agents. The other issue relates to SGLT2 inhibitors, and this is a wonderful piece penned by Dr. Braunwald in the New England Journal of Medicine, where he suggested that there is not just one mechanism by which SGLT2 inhibitors work. We always thought they were a diabetogenic prevention drug that was glycosuric, and it turns out that while that is a fundamental effect of these drugs, that these drugs may actually act through many other cellular mechanisms, perhaps through ketones, perhaps through decreasing insulin resistance, perhaps through other activity in many ways that one still doesn't comprehend, but they seem to work. Now, if you look at the sum total of the aggregate data, with SGLT2 inhibitors, and of course, Dr. Bhatt has been a pioneer and leader in that with the Soloist trial and with that particular SGLT2 inhibitor. But if you just think about this class, one of the things that has become very obvious with SGLT2 inhibitors, which we have not seen with any other drug class in heart failure, is that there is some kind of an effect on renal endpoints as well with these drugs, whether you're diabetic or you're non-diabetic with heart failure. Turns out that we have not seen that renal effect with enough precision in HFpEF, but we've seen that in HFrEF pretty reasonably. So these drugs are clearly placed for both heart failure with reduced ejection fraction, but more importantly also with heart failure with preserved ejection fraction. The cost effectiveness of using them in HFpEF is not as clear as with HFrEF, but suffice it to say that most of us would advocate the use of SGLT2 inhibitors in that scenario, at least for heart failure hospitalization reduction. Now, the third class that has shown clear benefit to some extent in the early trials are the GLP-1 agonists. And this is the Summit trial data showing the outcomes with tirzepatide for heart failure with preserved ejection fraction and obese patients. And this clearly showed that death from cardiovascular causes or a worsening heart failure event were impacted in a positive manner here with a significant difference with this drug class out to just as much as about 2 years. Now, it also improved quality of life, which is very difficult to show in heart failure-related pharmacotherapy trials, but it did show that. And what is interesting here is that the mechanism of action is becoming very, very important for us to think about. So one of the most important advances was to try and figure out what happens to the physiology of fat, if you will, that is actually pericardial or paracardiac fat. And it turns out that in a sub-study of the Summit trial, that tirzepatide use was associated with not only a reduction in epicardial fat, but also in paracardiac or visceral fat that is obviously biologically quite active. which has led some, including Milton Packer, to propose the adipokine hypotheses now, which I've never seen such a flurry of papers in JACC where the entire issue of JACC is nothing but related to adipokines. And I know, Deepak, you had a paper commentary as well, which I thought that Subodh Verma in your paper was probably one of the best written commentaries in that entire compilation. But suffice it to say, the idea here is that it's somewhat preposterous to only implicate one pathway in HFpEF, but the idea is that if you consider HFpEF to be a disease of obesity and of visceral fat changes, and that just like the neurohormonal hypotheses in HFrEF, that there is a adipokine hypothesis in HFpEF, where you have adipokines which are initially cardioprotective, but as disease starts to get manifest, they become compensatory, and once they lose their compensatory mechanism, they become maladaptive, as is the case with traditional neurohormonal therapy. That hypothesis has been proposed so that treating adiposity in patients with HFpEF may be a singular target. But of course, treating hypertension is equally important, because the population attributable risk of hypertension in HFpEF and heart failure in general probably outpaces the population attributable risk of obesity. One could argue that the definitions of obesity as we adjudicate them may be open for question, and we can discuss that. What is unique, though, about GLP-1 agonists is that while they seem to work in HFpEF, they don't seem to work in heart failure with reduced ejection fraction. In at least two trials, the LIVE trial and the FIGHT trial with liraglutide, have suggested that to be the case. And what that perhaps suggests is that the adipokine hypotheses may not be as important in heart failure with reduced ejection fraction. And in fact, the use of GLP-1 agonists in HFrEF may be more directionally prone to either no benefit or harm, and that is certainly an issue that needs to be kept in mind. Now, I'm going to move forward very quickly and point out to you some oncologically inspired therapies in heart failure. And quite clearly, cardiac amyloidosis is the first thing that comes to mind with all of the flurry of therapeutic interventions. Just to frame this for the audience, there are two kinds of amyloidogenic protein substrates. One is AL amyloid, the source is in the bone marrow, and TTR amyloid, the source is in the liver. And we now know very well that a number of treatments, either stabilization of the amyloidogenic proteins in blood, or the complete reduction of the generation or production of these drugs, of these proteins, may in fact be very, very important in reducing morbidity and mortality in patients with cardiac amyloidosis. Now, to frame this, the way in which you can reduce production of TTR, for example, in the liver, is through using silencing RNA, vaccine-like drugs, such as vutrisiran, or a antisense oligonucleotide drug like inotersen, or you have now CRISPR-Cas9 therapy, and we'll discuss that briefly because this is a very important construct that is developing where you're once and done, where you give a gene-modifying molecular scissor-like therapy that completely abrogates the production of these agents. The other strategy is to use TTR stabilizers, such as tafamidis or diflunisal in different areas. And so this somehow reduces the outcome from morbidity and mortality with amyloidosis. Now, one always wonders that once the protein isn't in the heart, why would these drugs actually work? What is it about the disease? Certainly, disease progression can be decreased by the use of these drugs, and that signal has been seen in most of the trials where NYHA class 3 or 4 patients with cardiac amyloidosis don't seem to benefit from drugs like tafamidis. And the reason they don't is because they don't remove amyloidogenic protein that is already in the heart. So what is the mechanism by which these amyloidogenic protein reductions actually work? And most likely, we are now understanding that the reason for this is that the prefibrillar species of these proteins that are abnormal oligomers that then deposit in the heart are actually directly cytotoxic, and they're directly toxic to the mitochondria and to other cellular elements. And by reducing that direct cytotoxicity, one can inhibit some of the actions on the heart. It's almost like reducing cytokines in sepsis, for instance, and improving cardiac function. So there are two mechanisms of action in our thinking of how amyloidogenic treatments work. Now, this is a CRISPR-Cas9 based technology, molecular scissors, just to give you a very, very rapid sense of how these work. Let's say you want to change a gene in the liver. You would actually take a lipid nanoparticle in which you would put a TTR-specific guide RNA along with this enzyme Cas9, and this would then, through endocytosis, enter into the nucleus in the liver, go in and basically edit out the TTR-producing gene, and in essence, it would reduce the production of TTR with just a single dose of medication. And you would say, well, what evidence do we have? And in fact, this movement has gone a bit quite far, with at least 36 patients dosed now, which have been reported, of which this represents about 33 patients who actually were fully dosed. And it shows that with a single intravenous dose of this particular medication, that there's almost a 90% reduction in TTR production with this for at least 3 years out so far, suggesting that there is, in fact, a possible vaccine for amyloidosis as well in the future. And this particular direction of therapy is a major advance in our thinking because, as I'll share with you, there are at least a few other examples that could impact heart failure. Now, the biggest advance, I think, in amyloidosis, which is still in its nascent form, is about actually removing amyloidogenic protein from the heart, which has already been deposited. And this is an antibody, N1006, which basically is a selectively binding antibody that binds to misfolded TTR amyloid fibrils, but not to native TTR. So it's highly selective to an abnormal oligomer that has already deposited. And the early data with infusion of this antibody in a few patients, and this is now the subject of a much larger clinical trial, is that you can in fact decrease the extracellular volume with the use of this antibody. So stay tuned for this. This may be a very important advance in the field. Switching gears for a moment to hypertrophic cardiomyopathy, myosin inhibitors have been a great advance. Again, our own Dr. Braunwald appeared to have single-authored a paper, once again at his tender age of 96, on the role of myosin inhibitors. And it turns out that myosin inhibitors have been a great advance, a great story which we don't have time to go into, from preclinical to translational biology to actual therapeutics and commercialization. But in essence, we now know that in obstructive cardiomyopathy, hypertrophic cardiomyopathy, that these agents decrease the need for septal reduction surgery, improve symptoms, reduce the LV outflow tract gradient, and we do not yet know if they improve mortality, and we do not yet know if they change sudden cardiac death. That is still a open question. But in terms of advances, there have been two important trials that have been recently presented. The first, I would say, is the Odyssey HCM trial, which actually asks the simple question, does a drug like a myosin inhibitor work in non-obstructive hypertrophic cardiomyopathy? And the result was a bit strange because it did not meet its primary endpoint. It suggested that it does not, that this drug class is useful only in the presence of obstructive HCM. But the problem with this was that surrogate markers such as NT-proBNP and LV mass actually reduced in this particular study, raising some doubt as to whether it was just a short-term follow-up in the trial that achieved a neutral results, because sometimes there are trials where there's separation of curves after a year, after 2 years, and that may be the case here, but we just simply don't know. The second important trial was MAPLE-HCM. In the algorithms that you always hear about HCM as well, let's start a beta blocker first, and if that doesn't work, then use mavacamten as a second agent. This was a head-to-head study of aficamten versus metoprolol directly, and this actually seemed to be superior to metoprolol in reducing the symptoms and in improving peak oxygen uptake on exercise physiology. So stay tuned for this of moving these drugs in obstructive myopathy to a more proximate algorithm component, and stay tuned for non-obstructive HCM. Now, a few words about the pathophysiology of HCM, and our particular group at the Brigham, led by Carolyn Ho and Cricket Seidman, showed very early on that one of the big problems with HCM is not just the myocyte, but it is actually the extracellular matrix, in the sense that when you do see left ventricular hypertrophy in phenotype obvious HCM patients and you do MRIs, a lot of what you see is scar or late gadolinium enhancement, suggesting that it's not just a disease of the cardiomyocyte. And it might very well be that there are two components to it, which is an extracellular component as well as a cardiomyocyte component, because we know that even in carriers of the mutant gene, that there is evidence of increased collagen turnover in these patients. Now, this can actually be looked at in the form of molecular scissors or gene editing work, and some of the basic science advances that Cricket Seidman's lab is making is in deactivating these pathogenic genes in HCM using a single drug. So this is actually a mouse model of a mutant form of... Did I do this? It's the...
That happens almost every day.
Not at all. And no one left the room, which is the most important thing. So I can still go on for a few more minutes. Thank you. So what you see here is that the use of a CRISPR-Cas technology, using, instead of a lipid nanoparticle, which is tropic to the liver, what is tropic to the heart is adenovirus. So you use AAV vectors to actually move the gene of interest through CRISPR-Cas technology. And you can see very nicely that in those that were treated with this, there was a 70% reduction in the area of fibrosis with this particular agent. So stay tuned for this, because we may in fact have a gene editing way of treating this by decreasing fibrosis. Now I'm going to quickly spend another 3 or 4 minutes to bring you up to speed with tackling a key vulnerability in heart failure and factors that influence transitional risk. So we know that we have to put people on GDMT, or guideline-directed medical therapy. We understand that. And in those with more advanced stages of symptomatic heart failure, we shift from neurohormonal therapy to what I refer to as invasive Laplace therapeutics, where you address the shape and the strain and stress within the heart and the cavity. You can use CRT for that, or you can use valvular disease treatments for that, or LVADs and heart transplant. But in between, one still has an opportunity for intervention. We haven't figured out what to do with the patients who leave the hospital exactly, who are on reasonable GDMT. How do we manage residual risk in these patients if they haven't reached the point of other advanced therapies? And in that sense, hemodynamically guided monitoring with implantable sensors, PA pressure monitoring, has been shown to at least decrease heart failure-related hospitalizations. Whether it reduces mortality remains uncertain at this time point. But there are some new advances that are coming up, and which is to actually look at the venous circulation and think about congestion in a much more proximate way. Turns out that your splanchnic venous reservoir actually acts like a ketchup bottle, and in fact, during sympathetic stress, will push blood into the IVC, which starts to buffer the system. And this whole notion of how we learned about heart failure as backward failure is perhaps not true. It's probably veno-forward failure, which one should think about in terms of redistribution of blood. And putting in a sensor that can in fact measure collapsibility of the IVC and its dynamic relationship to breathing might be a way to go. In fact, we have been working on just this and created a new physiologic parameter of an ambulatory congestion score that a clinician can use very easily, where we have shown with reasonable fidelity that the real paradigm shift with using this sort of a modality could be to actually use self-management for patients. So put the disease back in the hands of the patient, let them self-manage it with a clinically overseen model of care delivery, where there is a daily way of measuring whether a patient is still within physiologic realms or has transitioned into pathological realms of redistribution of blood flow well before the filling pressures go up. And that's the potential for this. And we are going to start a clinical trial called the NORM-HF trial next year on this. Now, just a few words about VADs and transplants. Deepak, do I have another moment to cover this? Yeah. So I will just point out that there is basically two concepts that I want to point out in advances in heart transplantation at this time point. One is that we have improved the sources of where we get donor hearts from, number one. And number two, we have improved the way in which we bring these hearts forward. And the second concept I want to point out to you is that we're now rethinking the way we think of strategies for caring for advanced heart failure patients into a paradigm of net prolongation of life. What is that? So the first observation is that there are about 75,000 patients with advanced heart failure in the US, and we service only about 7,500 a year, 3,000 with an LVAD, and about 4,500 with transplants. Now, there has been this increase in transplants largely because of donation after circulatory death, new sources. We won't go into the details of that, but I will point out to you that what has changed is that our old system of bringing hearts in little lunch boxes on ice has changed to much better preservation and now perfusion techniques. We won't go into the details of that, but that has expanded our reach. We can now go in and expand the ischemic time, which used to be 4 hours, to as much as 9 to 10 hours now in most cases. So we can actually access donors from anywhere. We've done heart transplants in Boston now from donors retrieved from Alaska, from Puerto Rico, and many other places, and we're doing this almost uniformly at this time point. Another technology with left ventricular assist devices, this is the HeartMate 3 pump, which Sinai has great experience with, of course, is a wonderful, fully magnetically levitated technology on a platform that has actually changed the way in which these patients can now live and survive on ventricular assist device therapy as destination therapy or as bridge to transplant. And this particular pump is frictionless. It actually has an artificial fixed pulse and is wide and consistent blood flow pathways, so there's less hemolysis. What has this translated into? Well, it has actually changed the median survival of patients to well over 5 years now. And young patients, less than 50 years of age, tend to survive out to 7 to 10 years without complications with this particular pump. And most of these advances have occurred because of the introduction of better engineering technology. But still there is a gap. Most people don't know how to express the benefits of LVADs. And so I just want to go over that with you. The type of patient we want to put an LVAD in is a patient who has either a median survival of about 9 months, which is an inotropic therapy bound patient, or a median survival of around 18 months, which is a patient who is in ambulatory class 4 heart failure. In these patients, the use of this technology will actually improve survival by more than 5 years. Now, what that means is there's very few therapies in heart failure that actually triple, quadruple, or even pentuple the survival, and this is one of them in well-selected patients. But it isn't survival with misery. It's survival with reduced the quality of life goes up. the burden of disease is reduced significantly in these patients, and NYHA class functional 1 or 2 is retained in almost 80% of patients out to 5 years. We have tried to create communication algorithms to help people understand when to refer these patients, how to refer these patients, and have even created something which is on the right side, which is lvaddecisionaid.com. You can access this website. You can, in fact, put in your patient's characteristics and derive a personalized outcome score out to what the expected survival on an LVAD would be today, out to 2 years or more in these patients. Now, one of the opportunities with LVAD therapy in patients, which is not accorded by transplantation, is the opportunity for remission in heart failure. If you look at this X-ray very carefully, there's an LVAD placed in the heart, but the drive line, which is the power source to it, is cut. This is called decommissioning of the left ventricular assist device, and instead of removing the devices, now we decommission them and leave them in the patient's chest. This is basically a way of treating patients, particularly young patients. They may actually have a 40% chance of achieving sufficient remission if you look at patients under the age of 50 with recent onset heart failure who have non-ischemic cardiomyopathy, 40% of them. And that's not an opportunity to be missed. So that's why we have been now pushing the idea of net prolongation of life. In fact, the young patients who have no comorbidities, when a transplant center looks at them, they say, this is a really juicy patient for transplant. And what we're saying is that that's the absolute wrong way of looking at it. That if you actually want to prolong that patient's life, you need to think about an LVAD first strategy in appropriately selected patients, take them through to another 10 years, and then do a transplant. Because if you take a transplant today, the median survival with a transplant is 12 years. The chance that a patient can be retransplanted is only 4 to 6%. If they need a retransplant. Whereas the median survival with LVADs in young patients is well over 7 years, and that's only because this technology has been around for 7 years or more that we've had the chance to measure it. Final words about xenogenic transplantation. This is still an effort in evolution at this time point. We have still not been able to overcome the immune challenges with this particular issue. And frankly, we don't know what to do with this in cardiac transplantation. We will learn from our kidney colleagues first and then move this to our arena in heart xenotransplantation. There are also social and ethical barriers and healthcare resource-based barriers that are critical in this. This was the pathology of the first porcine to human gene-edited heart transplant that was done. And by 60 days, this heart was lost. And when the autopsy was done, what was unique is that all of a sudden there was a complete loss of the microcapillary bed. There was capillary rarefaction. It was almost a very accelerated form of vascular rejection or antibody-mediated rejection. And we still don't understand this very well. And therefore, I think it's going to be a little while before we move this to the heart realm. Now, a few words about AI. You've already heard about this today, but I will just tell you where the field is moving on population-wide health with advances in heart failure. We now have EKGs that can in fact inform left ventricular dysfunction with reasonable fidelity, and this is going to be very important as a very cheap way of looking at who is developing LV dysfunction and who can be treated with preventative therapy early on using just electrodes. Now, how this is implemented with what cost configuration remains to be seen. Another very interesting AI technology is vocal biomarkers in heart failure. It's very interesting in that AI can help you pick up subtle changes in jitteriness or shimmer, which is amplitude sensitivity or stability, or the harmonics of to noise ratio in these, and even the phonation time as people are speaking. And you can pick up these changes very nicely and see who is actually decompensating and who is not. And maybe this might be even better as a congestion test proximate to even other IVC-based parameters. The other way of using AI in heart failure is to use it for phenomapping and for better guidance of who should get an ICD or not. In non-ischemic cardiomyopathy, we still are confused in today's day and age as to who should have an ICD. In ischemic cardiomyopathy is much more clearer, but maybe AI will help us get to better risk stratification. So I'm going to end here by pointing out that maybe the future is in bioengineering a human heart. This is Doris Taylor's work, where they take a porcine heart, decellularize it, basically down to its skeleton, and then take induced pluripotent stem cells from a skin. And we can basically then create a new heart, which can then be shipped back, and you can actually transplant that as an autologous heart transplant in the future. So this, we think, is going to be the future. So I'm going to end with this and point out that using CRISPR-Cas technology and vaccine-like therapy with molecules like silencing RNAs is probably the best future and the greatest advance in heart failure. Why? Because it will prevent it. We can prevent Lp(a). We can actually reduce PCSK9 with single drugs. Shown to your lower left is zilebesiran, which is a drug that reduces blood pressure. And we are even getting smarter with anti-obesity therapies. So if we can tackle lipids, hypertension, and obesity, we think we will get very far in this syndrome. And thank you so much for tolerating me for a little longer than I should have gone.
Beautiful. All right, then questions for Dr. Mehra? Either you send it or we have the. Okay. Yes.
When you decommission the LVAD, what if the person gets worse in heart failure? Do you reconnect it or?
No. So once it's decommissioned, it's gone. The reason for decommissioning is not to have the opportunity for recommissioning it or reanimating it, but simply to reduce the stress of the operation. So remember, the right heart is not supported, and putting them back on cardiopulmonary bypass could really be physiologically stressful. So that's why we prefer decommissioning. If the heart in remission becomes worse again, then we can always go ahead and do a transplant as a rescue. Yeah.
Okay, there are a few questions already. One is about the vericiguat making a weak comeback. Could you see a role for its palliation prior to escalating to a palliative milrinone?
Thank you. So I'll speak over it, I think. Yeah. So, so the first question was about vericiguat, which is cyclic GMP drug, and this agonist drug basically in the Victoria trial, which was in heart failure with reduced ejection fraction patients who had recent worsening heart failure, showed a very weak signal of benefit, about a 4% absolute reduction in the primary endpoint, not a clear mortality signal, but a heart failure hospitalization signal. It didn't get much pickup at that time. And then one of the things that was found in the Victoria trial was that patients with a BNP level at baseline of over 5,000 appeared to actually have harm. So another trial was done in non-worsening patients, in stable patients with heart failure, called the Victor trial. And that had a endpoint, primary endpoint, which was neutral. The secondary endpoint on cardiovascular mortality appeared to have a benefit, and one can only take secondary endpoints as exploratory in that situation. Meta-analyses suggested that there is some benefit, but if you do a Bayesian study and you think about the data on a Bayesian probability standpoint, we know there is some benefit of using vericiguat, but we also know that its effect size is going to be extremely small. And the probability that someone will have at least a 10% benefit is less than 30% on Bayesian grounds. So I'm not so sure that this is a major advance, but it is certainly an opportunity in case your patient is symptomatic.
So second question is on the ATTR. Why do you think the stabilizers have better data than the silencer in ATTR?
So actually the best study, the Apollo study with vutrisiran, actually has very good data on it. And the silencers such as tafamidis do have good data, but not great data. In fact, with tafamidis, if you think about it, they only the silencers only help, stabilizers only help in NYHA class 2 patients. In class 3 or 4, they don't. With the mRNA silencers, there was evidence that there was benefit even across the board in those patients. So I'm not so sure that one is better than the other, because in the clinical trials, they were actually not compared to each other, but as add-on therapy in many cases. So it's still unclear as to what that is. But I think the future will be of using silencers as long as they can be accessible and cheap.
Okay, so another question is, can you comment on the role of total artificial heart, such as titanium constant flow TAH, as a permanent transplant alternative?
Yeah, so it's a great question. So biventricular support with total artificial hearts is an emerging technology. I think the device that I'm most favorable towards at this time point is actually called the Bivacor device. It's a very small device. It's a very unique device in the sense that it doesn't have two chambers. It has only a single chamber, but it phase shifts into an RV or an LV. So it actually phase shifts in the way in which it flows blood, but it's a magnetically levitated rotor. But it does require hydrodynamic shift from right to left. This has been just tested in early feasibility studies. There have been 5 cases in the US that have been implanted as a bridge to transplant. The problem is that once you do a total artificial heart as a bridge to transplant in the US, the patient becomes a high priority as a status 1. The primary endpoint of these trials was to look at 30-day outcomes at a minimum, and most of these patients got transplanted within 2 weeks. And so we don't really know what its long-term fidelity is. The only long-term patient with the Bivacor device has been implanted in Australia with a 105-day outcome so far. So I think this one has some promise. Whether it will be a replacement to LVADs, I can't be certain, because excising the ventricles actually removes natriuretic peptides and actually causes duress on the kidneys in many ways. So I'm not sure that it's going to be a panacea, but it will be a selective option for most patients.
Okay, there are 2 more questions. One is, are there different treatments for mid-cavity hypertrophic cardiomyopathy versus apical hypertrophic cardiomyopathy?
I don't think we know the apical cardiomyopathy or the Yamaguchi type cardiomyopathy as it's known. I don't think it differs in many ways from the others. I think the same treatment can be employed, but if you take the Odyssey trial, one could argue that in apical cardiomyopathy, you might not get the same effects that you do with truly LVOT obstructive cardiomyopathy. So we don't know the answer to that. Great question.
Okay. And the last one is, in a non-compliant patient with severe systolic dysfunction, EF of 20% or less, do we first cath or first try GDMT and CCTA?
In a non-compliant patient, you send them to Dr. Sharma because he'll take care of them, right? No, but in a non-compliant patient, you know that GDMT is going to be very difficult to employ, and I think that in those patients, doing things that they don't have to worry about are a way to go. So for example, if a non-compliant patient has a left bundle branch block with an LV dysfunction, I actually think about CRT earlier than waiting for them to be on GDMT, because I haven't seen left bundle branch block improve very often with GDMT. So I think these are 2 separate etiologies. So there are different, you have to individualize to a certain patient's phenotype in thinking about these.
Fantastic, my friend. Great.